tabletop simulation for you. And we have a couple reasons for doing this. One, for those of you who haven't tried this yet, we want to have you watch us struggle through it. And we're going to do it twice because I have another point that I want to make with you. I want to show you how to do a tabletop, and then I want to show you what this checklist can bring to you that the standard checklist, the standard timeout doesn't. So we're going to do a tabletop simulation. This is our patient. It's a 68-year-old gentleman. Hopefully you'll hear that again when we run the checklist. He has severe peripheral vascular disease. He has pain in his legs when he walks more than a couple hundred feet. And he's had studies that show us that his aorta is nearly blocked off. And he needs an old-fashioned procedure in the days of so much minimally invasive stuff called an aortobifemoral bypass to bring more blood down to his legs. So a 68-year-old, bad peripheral vascular disease, and he needs an aortobifemoral bypass. And what we're going to do right now is a tabletop simulation. I have with me 4 people who were in that picture around the table. You can see that the oldest one there is me, and I'm going to play the surgeon. Next to me on my right is Lizzie. Across the table is Judy. Playing the administrator here in the room was Alex Arriaga, and our anesthesiologist at the head of the table, just like at the head of the bed, is Alvin, and Alvin Kwok is sitting here with me and is going to play the anesthesiologist part. So here's our checklist, and I think everybody with us on the call will recognize that this is the South Carolina Surgical Safety Checklist, and I think you'll see that what our team up here did at Harvard Hospital was we customized this baby right out of the block, and we called it the Harvard Hospital Surgical Safety Checklist. Now that's the minimum amount of customization that I want you to do at your own hospital. So now we at Harvard Hospital feel like we own this thing. Now, because our team here, which actually consists of one different person, let me go around and I'll introduce you before we start the checklist. Alvin Kwok is with me. You saw him. Lizzie Edmondson is here. Beth Norton, who is an operating room nurse who's helped implement the checklist at our children's hospital here in Boston, is with us and is going to play the part of the nurse doing the checklist. We're all sitting around the table here with a computer screen in front of us, and we're going to run through our checklist. Now, we may make some mistakes. We might stumble. We might say that looks weird or that sounds strange, and those things are because that's what we would do if we were sitting in a real conference room. We want to test this thing and think about, will this work in our hospital, and will it do the things that we want it to do? So, I want you to imagine now that we're standing in the operating room. The surgeon, of course, is off having some coffee or something, as is typical in many American operating rooms, and the nurse and the anesthesiologist are standing with a heavily sedated patient in the operating room, and they are going to begin the before induction portion of the checklist.
Okay, Alvin, before we induce our patient, let's go over some steps. Can you identify him with me? This is George Smith. He was born on January 1st, 1943.
Correct.
We're going to have a midline abdominal incision.
Mm-hmm.
And I have the consent here, which says aorta bifemoral bypass.
Right.
The site wasn't marked because, as we know, it's midline, so it didn't need to be marked.
Correct.
And our patient doesn't have any allergies.
Mm-hmm.
Did you do your safety check this morning?
Yes, we've checked the anesthesia machines and everything is correct and completed.
Great.
So moving on to the next portion about the specific anesthesia concerns or information. So we've examined the patient. Mr. Smith does not have an aspiration risk. In regards to blood loss, we're not expecting a significant amount of blood loss, but we've placed 2 IVs, and we've sent for a type and cross. Beth, is there blood available?
I'll call the blood bank and have it sent to the room. Do you want it in the room or?
Yeah, that'd be great.
Okay.
And we've placed an upper body bear hugger to prevent hypothermia. And for our venous thromboembolism prevention, Mr. Smith has boots on, and we will be using anticoagulation during the case.
Okay, great.
All right, so the patient now is going to be properly positioned and then prepped and draped, and the operating room team now is going to assemble around the patient. So the surgeon has scrubbed and come into the room and moved to the side of the patient, and it's time to do our before skin incision portion of the checklist. And in our hospital, we've decided that the surgeon actually is going to lead this portion of the checklist, because in our hospital, it's been traditional actually for the surgeon to help lead the timeout. So we'll go ahead with this portion of the checklist. If I could have everybody's attention and get everybody to stop what they're doing for a minute. Dr. Clark, is this a convenient time for the anesthesiologist?
Yes, it is. Go ahead, Dr. Berry.
Fantastic.
I'm ready.
All right. This is George Smith. The procedure that we're going to do today is an aorto-bifemoral bypass. We're going to approach this through a midline abdominal incision. The patient is positioned in the supine position, and the essential imaging that's needed for this case is available and displayed on PACS. Alvin, has the antibiotic prophylaxis been given in the last 60 minutes?
It has. We've given 2 grams of ANSEF about 10 minutes ago, and we don't plan on redosing during the case.
All right. Now, we're going to go ahead and move to the briefing portion of our checklist. We're going to start by going around the room quickly and introducing ourselves by name and by role. I'm Bill Berry. I'm the surgeon for today's case.
I'm Alvin Kwok. I'm the anesthesiologist.
I'm Lizzie Edmondson, the scrub tech. I'm Beth Norton, the circulator.
All right. Now I'm going to do the surgeon discussion. What we're planning for Mr. Smith today is an aorto-bifemoral bypass. Now, one of the things that's a little bit different about this case than most of our cases, in addition to having terrible blockage in his abdominal aorta, Mr. Smith also has a small aneurysm. Now, I can't tell from the films and the studies that we had before surgery whether or not there's a clear neck below the renal arteries, so there is a chance that I may need to apply a cross clamp above the renal arteries for a brief period of time. If I need to do that, I will let you know, Alvin, so that you can prepare for that before we put the clamp on. I expect that this operation is going to take about 3 hours, barring any kind of unforeseen complications. We expect to lose less than a unit of blood, less than 500 cc's. For this case, I'll need one of my standard Gore-Tex aortic bifurcation grafts, and I would like to have fluoro on standby.
Okay, I'll give him a call.
Fantastic, thank you. Alvin?
Great, we'll move on now to the anesthesia discussion. So we're going to use general anesthesia during this case. And thank you, Dr. Berry, for letting us know about the possibility of clamping above the renals. We'll be sure to be prepared for that. Also, while intubating, we noticed that Mr. Smith has an anterior larynx, and so if we do have to extubate outside of the operating room, we'll have to make sure that anesthesia is, that we're there during the extubation.
Okay.
Lizzie and I checked all the sterility indicators. They were all fine, right, Lizzie?
Yes, they were.
And we've got all your standard equipment, plus the graft in the room. Is there any other special equipment you might anticipate for today, Dr. Berry?
I don't think so.
Okay, I think we're good to go.
All right, before we begin, I want to make sure that everybody understands if they have any concerns. If you see something that concerns you during this case, I want you to please speak up. All right, so the patient has the operation. The operation goes as planned, They actually are able to do it without putting a cross clamp above the renal arteries. It takes less than 3 hours to do. The fascia is now closed, and we're coming to the before patient leaves the room portion of the checklist where the nurse reviews with the team.
So Lizzie and I did our instrument, sponge, and needle count, and they were all correct. Dr. Berry, could you just go over the name of the procedure performed for documentation?
Yes, we did an aorto-bifemoral bypass with a plasty of the right femoral artery.
And I've got that piece of aorta wall. Did you want me to send that off to pathology?
That would be great.
Could you just sign the report for me before we leave?
Yes, I'll do that before I leave the room. Now we want to move to the debriefing section.
You know, I don't think we had any real equipment problems, just some dull scissors, and I'll make sure those are labeled and sent out to be sharpened.
As for anesthesia, I think the patient will leave the patient intubated, so I'll be sure to talk to the recovery room that we need to make sure an anesthesiologist is there when we extubate.
Okay. Before we all leave the room, is there anything that we could have done to make the case safer or more efficient?
I don't think so. I thought things went smoothly.
Yeah.
I agree.
All right, so we'll go ahead and put on the dressings and get the patient ready to transfer to the recovery area. All right.